بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله. I'm Dr. Tarek Eid, Professor of Ophthalmology at Tanta University, and I'd like to welcome you and going to present for you today a lecture about glaucoma. Our lecture will be divided into two parts. The first part will be a general introduction to glaucoma, and the second part will include the primary open-angle glaucoma. The first part of the lecture will consist of clinical significance of glaucoma, definition, classification, pathological overview, and then we will discuss the diagnostic measures of glaucoma, including intraocular pressure, anterior chamber angle, optic disc examination, and visual field testing in glaucoma. The clinical significance of glaucoma, we should know that glaucoma affects around 80 million population worldwide, and about 10% of these patients are legally blind from glaucoma, so we consider glaucoma is the leading cause of irreversible blindness, and it's considered the second most common cause of bilateral blindness after cataract. And actually, glaucoma affects all age and ethnic groups of the society with major economic and health problems. So how can we define glaucoma? Glaucoma can be appropriately defined as a group of pathological disorders with different pathophysiological mechanisms causing progressive ganglion cell loss and optic neuropathy, which are characterized by a specific pattern of optic disc and visual field changes. And actually, these changes are partly related to a relatively high intraocular pressure. How can we classify glaucoma? We usually classify glaucoma into either adulthood or pediatric types, and each one of these will be divided into primary and secondary, and then the primary will be divided into open angle and closed angle according to the angle of the anterior chamber. Also, the secondary will be divided into open angle and closed angle. So if we go for these classifications and understand what are the clinical types of glaucomas and why we say it is glaucomas, it's not only a single disease. We can see the major and the first clinical entity of glaucoma is the open angle type of glaucomas, and this can be primary or secondary. Primary open angle glaucoma, like the high tension type, the low tension type, and the juvenile onset primary open angle glaucoma. The secondary types of open angle glaucoma include steroid-induced glaucoma, pigmentary glaucoma, exfoliation, lens-induced, sometimes some traumatic glaucoma like angle recession, inflammatory glaucomas, some surgically induced glaucomas, and also glaucoma with increased episcleral venous pressure. The second major type of glaucoma is the closed angle glaucomas, and this group of glaucomas characterized by closure or narrowing and closure of the anterior chamber angle, and they can be divided into primary angle closure glaucoma or secondary. The primary type has suspected primary angle closure or subacute or intermittent types, acute primary angle closure, chronic type, and also we have plateau iris syndrome. The secondary angle closure glaucomas include aqueous misdirection syndrome or malignant glaucoma, neovascular glaucoma, glaucoma associated with iridocorneal endothelial loss, also phecomorphic glaucomas, some surgically induced glaucomas like pupillary block and epithelial ingrowth, other forms of glaucoma, of inflammatory glaucoma, also glaucoma associated with retinal disorders. The last major variety of glaucomas are the glaucomas in infancy and childhood, what we call pediatric glaucomas. And these include primary congenital or infantile glaucoma, where there is an isolated abnormality in trabecular meshwork only, or maybe glaucoma associated with other congenital anomalies like aniridia or Peters anomaly or Axenfeld-Rieger syndrome. Also glaucomas in the phecomatosis like Sturge-Weber syndrome or neurofibromatosis. We have glaucoma associated with systemic congenital anomalies and the secondary pediatric glaucomas which occur as acquired glaucomas in childhood like steroid-induced or traumatic or aphakic glaucomas. So we talk about the pathophysiological physiology of glaucoma. If we want to talk about the pathophysiology, we have to first understand the mechanisms of aqueous humor formation and outflow. Aqueous humor is formed by the ciliary processes, and we have about 70 major ciliary processes formed of double-spaced or double-layered epithelium and has a vascular core. And aqueous is formed by three major mechanisms: diffusion or ultrafiltration or active excretion. And then aqueous is secreted into the posterior chamber, as we see here, and it moves through the pupil into the anterior chamber. And in the anterior chamber, it will go towards the trabecular meshwork, where it forms about 80% of the outflow, and this is a conventional outflow. It goes through the trabecular meshwork, Schlemm's canal, and then collector channels, and after that to the aqueous veins and episcleral veins. The other method or the other way of outflow is the uveoscleral outflow, and this represents about 10 to 20% of the outflow, and where the aqueous will pass through the face of the ciliary body between the iris root and the scleral spur into the suprachoroidal space, and from the suprachoroidal space will go to the emissory veins around the vortex veins. So what happened if outflow is obstructed? It means that the aqueous will not pass outside the eye properly and will increase the pressure inside the eye. Why the outflow can be obstructed? The mechanism is not fully explained, but it can be due to either alteration of the trabecular meshwork or collapse of Schlemm's canal, alterations of intrascleral channels, or maybe corticosteroid sensitivity. The other pathophysiology in glaucoma is the mechanism of neuronal damage, because we know glaucoma is an optic neuropathy. So what causes the ganglion cell axons and the nerve fibers in the optic nerve head die? There are many possible mechanisms. Not one mechanism can explain all the damage. These mechanisms may include apoptosis of the retinal ganglion cells or axonal transport blockage, sometimes related to the ocular biomechanics, or optic nerve head ischemia, or may be related also to changes in CSF pressure and the translaminar crepuscular pressure difference. Also, some theories said it could be retrograde transsynaptic degenerations coming from the occipital cortex and the lateral geniculate body. Now we will move to the glaucoma diagnostic measures. How can we diagnose glaucoma? We diagnose glaucoma by examining first the intraocular pressure, the optic disc, the retinal nerve fiber layer, the anterior chamber angle, and then we do some investigations like testing the visual field, examining the cornea and corneal thickness, also the neural pathway, and also the optic nerve head blood flow. We are going in this part of the lecture to focus on the intraocular pressure measurement, optic disc and nerve fiber layer examination, anterior chamber angle examination, and visual field testing. So how can we measure the intraocular pressure? And first, what is the intraocular pressure? The normal intraocular pressure is 2 standard deviation of the mean, which is 15 plus or minus 5 millimeter mercury. And we know this is the pressure where there is a balance between the aqueous formation and the aqueous outflow. And we know that there is some diurnal variations of the intraocular pressure throughout the day, which can be around 3 to 6 millimeter mercury. But this variation will increase more in the presence of glaucoma. Also, sometimes the pressure is more than the average, but still the patient does not have a neuronal damage. And in this case, we consider it ocular hypertension. How can we measure the intraocular pressure? We have many machines that can be used to check the intraocular pressure, like the Schott tonometer, the applanation tonometer, the AirPath, the Tonopen, the iCare, and the Perkins tonometer. Let us see, just in brief, some examples of the methods to test the intraocular pressure. This is the Schott tonometer, and this is the oldest machine used for examining the intraocular pressure, where we measure the area of deformation of the anterior surface of the cornea by a fixed weight or a fixed amount of force. Another example is the Goldman applanation tonometer, and this is a machine which is mounted on the slit lamp where a cone touches the eye and applanates an area, small area of the cornea, and you can see we're using cobalt blue light, and this prism will touch the cornea and applanate a small area of the cornea, and when we look to the slit lamp we will see two semicircles like this, and when they touch, the inner edges touch, we consider this a balance and we can have the reading for intraocular pressure. Other methods like the tonopen. This tonopen is a handheld machine and can indent or applanate only 1.5 millimeter of the cornea, and you can have multiple readings until it gives us the final reading. Also, an applanation using an air jet. As you see, an air jet is pushed or forced into the cornea to applanate, and when it comes back, it is received by a sensor to check the pressure. Another machine also is the eye care rebound tonometer. Like this very rapid movement which touch the cornea, and the rebound force is received and check the pressure. There are some new modalities for intraocular pressure measurements where they don't depend on the corneal thickness or corneal contour, like the dynamic contour tonometry, also the ocular response analyzer, which check the corneal hysteresis, and there are now a home tonometer which can check the intraocular pressure by the patient himself. The second method of examination is examination of the anterior chamber angle, which we call it gonioscopy. Gonioscopy can be divided into two methods. Direct gonioscopy, where we use a Keppe type lens. In this type, we look directly to the angle, or indirect gonioscopy, where we use a Goldman type lens or Zeiss type lens. In this case, we look through a mirror, and the mirror gives us the opposite angle. So we see always the angle opposite to the mirror. What we can see in the anterior chamber angle, this is the view of the anterior chamber angle with a superior, inferior, temporal, and nasal. So what is the anatomy of the angle that we should see? First, we see the Schwalb's line, which is the termination of the descending membrane of the cornea, and this is a white band at the termination of the cornea. And then we see this pigmented strip, which is a trabecular meshwork. After that, we will see a whitish glistening band, which is a scleral spur, and after that, towards the iris, we will see the ciliary body band, which is considered to be the ciliary body face, and then we will have the iris root after that. So these are the structures we should see in a normal and open anterior chamber angle. Also, we use the gonio lens, especially the Zeiss type gonio lens, to do an important test, which is indentation gonioscopy or dynamic gonioscopy. And this indentation gonioscopy differentiates between the appositional or synechial narrowing or angle closure. If the angle is narrow, just narrow, but not touching, but not fibrosed, we call it appositional angle closure. But if there is fibrosis and adhesions between the periphery of the iris and the periphery of the cornea, we consider it as synechial angle closure. If we push on the lens, on the cornea by the lens, and it will push the aqueous to the periphery. If there is only apposition but no adhesions, then the aqueous will open this apposition and the angle will be seen open. But if the narrowing is due to adhesions by fibrous tissue, which is synechial angle closure, in this case, the aqueous will not open the angle, so we still cannot see details of the angle. So this is what we call indentation or dynamic gonioscopy. What are the abnormal features that we can see in the anterior chamber angle during gonioscopy? First, we can see a narrow angle, and we can measure this angle in degrees. So we have a widely open angle like this, which is about 45 degrees, or it can be a 20 degrees narrower, or 10 degrees, or even less when it is totally closed. Also, we can see here excessive pigmentation of the trabecular meshwork during gonioscopy. Also, we can see broad peripheral anterior synechiae. You can see here that the iris periphery is adherent or attached to the periphery of the cornea. There is no details at all for the angle. Another finding is to see new vessels in the angle. These new vessels are seen crossing the anterior chamber angle here from the iris to the periphery of the cornea, which you can see a neovascular glaucoma or other neovascularization. We have also objective techniques of angle examination, and these are things which are recently introduced, like the shine flog camera, also the ultrasound biomicroscopy, and we have also the anterior chamber or anterior segment optical coherence tomography. These are methods, new methods to objectively and quantitatively examine the anterior chamber angle. The third issue in diagnosing glaucoma is examining the optic nerve head and the retinal nerve fiber layer. How can we examine the optic nerve head and nerve fiber layer? First, clinically by either the direct ophthalmoscope or by the slit lamp using a non-contact lenses or contact lenses. So we can do what we call slit lamp biomicroscopy. What are we going to see? We will see first the optic disc. But before we see the optic disc, other methods of examination of the optic nerve head is to do optic disc photography. And this optic disc photography can be either monoscopic photos or can be stereoscopic photos where we can see three-dimensional and see the depth of the cup or elevations of the disc. Also black and white photos which can show us defects in the retinal nerve fiber layer. Now, how can we assess the optic disc and the nerve fiber layer? When we see the optic disc, like what we see in the picture now, we have to comment on these following things. The size, whether normal or small or large. The shape, usually the shape is slightly vertically oval, but it can be tilted, it can be rounded, it can be oval. The margin, if it is clear, defined, or blurred. The color of the optic disc, so we can differentiate between a normal color or hyperemic disc or pale disc. Neuroretinal rim. The neuroretinal rim is the area where the nerve axons pierce and enter the optic nerve head. And this is usually, as you can see, pinkish in color, while the optic cup is the area whitish in color because there is no neural tissue inside in this area, and even you can see the laminar cribrosa pores through it. And then we can judge on the cup disc ratio. Usually we do either the vertical cup disc ratio or the horizontal cup disc ratio or both. We measure the area of the cup compared to the area of the disc, and then look to the blood vessel distributions starting from the central trunk and then the upper and lower divisions, and after that the nasal and temporal divisions, and also the arteries and the veins. And then we look to the peripapillary area if there is atrophy around the optic disc, we will call it peripapillary atrophy. And after that we look to the striations of the nerve fibers which go through the superior and inferior pools corresponding to the upper and lower arcuate bundles, and these striations will form some hatchings over the blood vessels, and this represent the retinal nerve fiber layer superiorly and inferiorly. Now, what are the characteristic features in the optic disc which can be specific to glaucoma? Or what are the glaucomatous changes in the optic nerve head and nerve fiber layer? This can be changes in the rim, where there is loss of the neural tissue, whether focal or localized, notching or diffuse thinning, and also changes in the optic disc, in the optic cup, like documented concentric enlargement of the cup or asymmetry of the cup between the two eyes, vertical extension of the cup or large cup disc ratio. Also, if there is pallor of the optic disc, and vascular changes like localized disc hemorrhage crossing the edge of the disc, pyonetting sign, pairing of circular vessels, or progressive vascular lobes. And then we can see peripapillary atrophy or retinal nerve fiber layer defects, which can be localized defects, wedge-shaped defects, or generalized defects. Let us have some examples of these glaucomatous optic disc changes. First, I want to show you the difference between a large disc with a large cup and a small disc with a filled cup, because this can be misleading. Sometimes you see a large disc with a large cup and you consider it glaucomatous, but it is not. It's just because the disc is larger than normal. On the other hand, if you see a patient like this is the right and the left eye with asymmetry of the cupping. You can see that the cup in the right eye is smaller, around 0.3, while the cup in the left eye is large, around 0.6. So this is asymmetrical cupping and also could be diagnostic for glaucoma. We can see some localized changes like this inferior focal notching and inferior pit in the optic nerve, or we can see vertical cupping, which the cup is extending superiorly and inferiorly, or concentric cupping, where the cup extends diffusely in all meridian. Also, we can see disc hemorrhages, which is a flame-shaped hemorrhage crossing the edge of the optic disc. Again, there is also nasal shift of the blood vessels with pyonetting sign. We can have advanced disc damage, whether diffuse shallow cup or total cup with venous lobes. This is an end-stage procedure. In the peripapillary area, we can see peripapillary atrophy, as you can see here, with zone alpha and zone beta atrophy. Also, in the nerve fiber layer, we can see some slit-like defects, which actually not characteristic, but more characteristic is the wedge-shaped defects that you can see here, whether in the colored or the black and white photos, or you may not see defects at all. It's generalized loss. There is no localized defects here. New methods of examination of the optic nerve head and nerve fiber layer are the computerized image analysis using the laser technology. We have the confocal laser scanning ophthalmoscope. Also, we have the optical coherence tomography of the optic disc and retinal nerve fiber layer. Also, we have the laser scanning polarimetry or the JEDEX. These are new objective methods for examining the optic disc and nerve fiber layer. The last item in examination of the glaucoma is the perimetry and visual field examination and glaucomatous visual field testing. What is visual field examination? And first, what is the visual field? The visual field is a three-dimensional island of vision surrounded by a sea of darkness. So you know that what you see, all what you see is the visual field. But you don't see the whole universe. Your field is limited. Outside this field for you is a dark area. And we should remember that every point in the retina is projected to a certain location in the visual field. The fovea is the point of fixation, and so it's projected straight in front of you. But remember that it's like a camera. The visual field usually it's upside down and laterally reversed. So what's right usually is projected to the left visual field. What's in the temporal part of the retina is projected to the nasal visual field. And what's in the nasal part of the retina is projected to the temporal visual field. And what's in the upper part of the retina is projected to the lower visual field. And what's in the lower part of the retina is projected to the upper visual field. That's important to understand. Also, what are the boundaries of the visual field? We say that it's an island of vision. What are the boundaries of this island? This island extends superiorly about 60 degrees because it's restricted by the eyebrow. And nasally, it also extends 60 degrees because it's restricted by the nose. Inferiorly, it's about 75 degrees because it's slightly restricted by the cheeks. Temporally, it extends around 100 degrees because there is no restriction for the field temporally. So these are the boundaries of the visual field. Also important to know what is the blind spot. The blind spot is the area in the visual field corresponding to the head of the optic nerve. Why? Because this area does not receive visual stimuli, because there is no photoreceptors in this area. That's why they consider it dead or blind spot. It is located temporally in the visual field. Remember that the optic nerve head anatomically is on the nasal side, so it's located temporally and around 10 to 15 degrees from the fovea or from fixation point and slightly below the horizontal meridian. And the blind spot is to the right of fixation for the right eye and to the left of fixation for the left eye. How can we examine the visual field? The visual field is examined by two methods, either the manual or the kinetic perimeters, and these are the old techniques for examination of the visual field, or the most recent now is the automated or static perimeters. We will be focusing more on automated static perimeters, which are currently in practice. Important also to know how this automated perimeter define the points of the visual field and define what we call the boundaries or the isopter. The isopter is the boundary between visible and invisible points of the visual field. In static perimetry, a boundary stimulus is presented, then a bright stimulus is presented, then decreased gradually by 4 decibel steps until it is not seen, and then increase slightly by 2 decibel until it is seen. And here we can consider these are the threshold between visible and non-visible stimuli. When we consider a peripheral isopter is closer to fixation, when the boundaries come close to fixation, we say that the field is contracted or narrowed. And if this is diffuse, so it's generalized contraction of the field. But if it is localized in only one area, we consider it as a localized contraction or a step, like what we call the nasal step in glaucoma. Let us see what are the visual field loss in glaucoma. These are the characteristic features in glaucoma that we say it's specific patterns. First, we can see enlargement of the blind spot. Second, we can see a paracentral scotoma, and then arcuate scotoma, where it arches around the fixation. There is also a nasal step, where it's a localized contraction of the visual field. And then the arcuate scotoma can be upper and lower, and is considered as annular scotoma. It can have also altitudinal or hemifield defect, and this can progress to a tubular field or total loss with temporal island. Let's see the evolution with automated static perimeters. Here's an example of a normal visual field, completely normal. Another example was a patient with generalized reduction of sensitivity but no localized defects, which can be an early finding in glaucoma. Here is another patient with a paracentral scotoma and also some enlargement of the blind spot, which is an early stage of glaucoma. Another patient who has a nasal defect or a nasal step, localized peripheral contraction in the visual field, and then can have also an annular or upper arcuate scotoma. This is an upper arcuate scotoma which extends from the blind spot to the horizontal raphe in the other way. This upper arcuate scotoma can also have another lower arcuate scotoma and will form what we call double arcuate or annular scotoma. More progression of the visual field will end with a tubular field defect, as we can see only a tiny area in the fixation. The patient can see through it, which we call a tubular field, and also can have some temporal crescent. So these are the visual field changes that can develop in glaucoma patients. We should also point to some important item, which is the reliability parameters of the visual field, where we call it fixation losses, because fixation losses, the patient should keep fixation on the point in the machine and not move his eye while doing the test, and a field could be unreliable if fixation losses are exceeding 20%. Also, a false positive response, where the patient responds to the sound, not to the visual stimulus. And unreliable field effect is considered if the false positive responses are more than 33. Also, false negative responses where a patient fails to respond when a previously visible stimulus is presented. Unreliable. Unreliable field if false negative responses are 33% or more. This ends our introduction for glaucoma, and I like to conclude by few multiple choice questions just to test your ability to understand what we have said. First question, which one of the following statements regarding glaucoma definition is true? It is a disease with high intraocular pressure, or a disease with a specific type of optic neuropathy, or a disease with obstructed aqueous outflow, or a disease with high intracranial pressure. What do you think is the most important, is the most accurate answer? Second question, a statistically normal intraocular pressure cannot be associated with glaucomatous damage, or glaucomatous damage always evident once pressure exceeds this value, or has measurements fixed at different times of the day, or is defined as the mean plus or minus double standard deviation. The third question, which one of the following scotomas is characteristic for early glaucomatous visual field changes? Central scotoma, or paracentral scotoma, or annular scotoma, or altitudinal scotoma? After you thought about the questions, this is a model answer for the questions before, and I'd like to thank you very much for your kind attention. Thank you.